neonatal jaundice, newborn jaundice. So, if you would have seen a baby is born in your families or in your relatives, they would have told you the baby was kept under the blue light for 1 day or so. So, that is nothing but the baby has got jaundice. So, there are two types of jaundice. One is pathological, so which usually occurs before 24 hours of life, and the physiological jaundice, which we most often see in our day-to-day life, in the newborn babies. So, almost 8 out of 10 babies develop jaundice, the clinical jaundice. So why the babies are developing this jaundice? So when the baby is born, they are born with high hemoglobin levels. What is happening is the hemoglobin babies, it's almost around 20-21 also. The hemoglobin is getting broken down. It breaks down into iron and biliverdin. The biliverdin is getting converted to bilirubin, which is nothing but the jaundice, which we test in blood. Biliverdin is getting converted to bilirubin, and the bilirubin, after getting conjugated, it goes out of the body through urine or stool. So what is happening is on day 3 or day 5 of life, what we are seeing, usually the jaundice in all the babies, like I was telling you, it rises like this and it automatically, slowly, gradually falls off. But when it is above the threshold, when it crosses the threshold limit, that is when we have to intervene. So intervention is, the treatment is nothing but we have to keep the baby under the phototherapy light. So it ranges. Suppose say a baby developing jaundice on day 3 will have a kind of lower cutoff value. Day 5 will have higher cutoff value. So depending upon the cutoff value, there will be treatment. So we'll decide whether the baby requires one light or double surface, like 2 lights or so on. So suppose what are the risk factors? We say if mother is O negative and baby being positive. So Rh negative pregnancy we'd call, mother A negative and baby positive, any negative and positive. So that itself is a risk factor. And ABO incompatibility, mother being O group and baby A, or mother being O and baby being B blood group. So these are the risk factors. Suppose the feeding is not properly established. Suppose the baby is not latching well, not feeding well. This is again a risk factors for the baby to develop jaundice, because the bilirubin is not getting washed out from the body through urine or stool. Through enterohepatic circulation, it just again gets unconjugated and again it's reabsorbed into the blood. And even hypothyroidism itself is a risk factors. So these are some of the risk factors. Suppose baby is born through, suppose say a vacuum delivery or normal delivery. If they develop cephal hematoma, there will be a lot of hemoglobin. The breakdown of the hemoglobin happens there and it will lead to jaundice. That is also a risk factors. And there are other syndromes like Gilbert syndrome, Crigler-Najjar syndromes, which we'll have to do, further testing to see. So whenever a baby develops jaundice, depending upon the level, the treatment would be there. We'll be treating with the phototherapy lights in the hospital. And when we discharge also, we'll be explaining the signs, the signs and, the risk factors to the patient. So any baby who has received phototherapy light during the hospital stay, we'll ask them to come early to again get the bilirubin level checked. If any, like I was telling you, Rh negative pregnancy or ABO incompatibility babies who are not feeding well, who is having a significant weight loss, all these are risk factors. So whenever we send the babies home, we ask the parents to come back, say after 48 hours, 72 hours to get the bilirubin checked. Suppose if this is getting neglected, if even though the baby is having this clinical jaundice, if we neglect this, so what will happen is the level keeps rising in the blood, and where a simple treatment of giving the phototherapy light would not be sufficient if the bilirubin level has gone up to certain extent, where we might have to do double volume exchange transfusion. That means the baby blood has to be removed and has to be replaced with the donor's blood. And sometimes even if it crosses to certain extent to very high level, that might even cross the blood-brain barrier and reaches the brain, and it will cause irreversible damage to the brain. So it's always be vigilant and always get your jaundice levels checked even after your discharge, according to your doctor's advice. Thank you.